I could tell you that he's a graduate of UCLA Medical School, Stanford University, and Harvard. I could also tell you that he's been awarded such prestigious awards from America's best physicians, America's best surgeons, America's best urologists. I could tell you that Boston Magazine has done a write-up on him. But instead, what I want to tell you is that Dr. Clifford Gluck has been a friend of mine for the past 30 years. I've met him when he was still doing his fellowship at Mass General and here at the Brigham and Women's Hospital, and we've been friends and colleagues since then. I also want to tell you that he's not just my physician, but he is my family's physician. Not only did he treat me when I had prostate cancer, but he treated my father as well when he was diagnosed with prostate cancer. So it gives me great joy and pleasure to introduce to you a person that's on the cutting edge here in Boston. He's now specializing in sexual medicine, in urinary incontinence, and he's going to give us an update of some new and innovative ways to treat some of the complications of prostate cancer. Let's give him a warm reception for Dr. Clifford Gluck.
Thank you, Dr. Taylor. And that was, it's about the nicest introduction I've ever heard. I really appreciate that. I also want to thank Tom and Juarez Farrington for asking me to come tonight, and thank PHEN for having me here. I think it's a wonderful organization, and I was very interested to hear that there's so many opportunities for people to be enrolled in clinical trials. But tonight, what I'd like to talk to you about is actually not prostate cancer itself, but what happens after you got treated for your prostate cancer, and how are you dealing with the aftermath of everything. Let's see, how to advance it? Click it? Oh, well, whoops. The mouse on the right. Sorry. Oh, it's here. So, how can I get the big slide back up? Right click it. What? There. Okay, that's fine. Okay. Just click on the right side. Just click. Okay, very good. Thank you. Technically challenged there. So I was at a conference in October out in Arizona, and I was standing at the deck of the hotel and back and looked out, and I saw this giant mountain. And it brought to mind that we all face challenges in our lives, and prostate cancer is about one of the biggest challenges that you can face. It is like climbing a mountain. And like climbing a mountain, it's always further than it looks, it's always taller than it looks, it's always harder than it looks. Those are the 3 rules of mountaineering. So just about myself, Dr. Taylor gave a wonderful introduction. I want to say that when I trained, when I trained here about 30-odd years ago, we were just learning about prostate cancer at that time, and the treatment was a nerve-sparing radical prostatectomy. That was revolutionary because not very many years before that, the surgery for prostate cancer was abysmal, and the cure rates were bad, and the outcomes were quite bad and surprising. So after doing hundreds and hundreds of radical prostatectomies, new technologies kept happening. Along came robotic surgery, so we switched to doing minimally invasive radical prostatectomies with a robot. And now we've progressed even further than that to non-invasive technologies, focal therapy, ablative therapies. But that's, again, not what I'm talking about tonight. Just like the treatments for prostate cancer, the treatments for what happens after your prostate cancer have changed dramatically. And there are lots of new options which I don't think many people in the general prostate cancer community are aware of. And that's what I hope to bring to you tonight, is to tell you a little bit more about some options that are out there for men to make your lives better. So after your prostate cancer, what could you expect? A catheter, incontinence, erectile dysfunction, some loss of penis length and loss of libido, and really a long quest about looking for normality. This is how we all feel after being treated for prostate cancer, you know, alone, exposed, urinating on yourself, and just very surprised at the condition. This was a piece of art in Helsinki at a port that I thought was just, it almost was irresistible as a metaphor for prostate cancer. Whoops. So every patient really wants to know, when can I go back to being normal again? All right, let's tackle these problems one by one. Leakage, that's usually the number one concern on any man's mind. You're usually reassured by your surgeon, your radiation oncologist, your doctors that leakage is going to get better. And despite all sorts of waiting, Kegel exercises, therapy, it hasn't gotten better. So Kegel exercises, time, pad use, incontinence clamps, pelvic floor therapy are all the traditional treatments for leakage. So after failing Kegels, after being done with diapers, some men end up with a clamp. This is actually the best one that I've ever found. Some of the others look like they came out of some medieval torture chamber. But this is a Weisner urinary incontinence clamp, and I mean, it's a solution for incontinence, but it's not a great solution. This is a TENS unit. Some physical therapists use this. It's not very successful, and in fact, most men would not use this at all unless they wanted to use it for entertainment. So it's really, it boils down to how soon you will become continent. And even when a man thinks that he's achieved dryness, he will do some physical activity, lift something heavy, and then find out he's still leaking. And how do we deal with that? How can we make that better? So stress incontinence happens because we're born with 3 sphincters, but after prostate treatment, we're only left with 1 sphincter. And that 1 sphincter is just down at the pelvic floor. It's muscles that you can control. You can feel them. You can stop your urinary stream with those muscles. But the other muscles at the bladder neck and at the prostate, those have been removed or they've been treated so that they're not functional anymore. When leakage occurs, it occurs with a strong cough, a sneeze, or activity. There's another solution to treating the sphincter, and this solution is called PHEN. It's high-intensity focused electromagnetic technology. So PHEN uses a magnet like an MRI, but it's a lot smaller. In fact, you can just sit down on this thing fully clothed. It's completely non-invasive. It's FDA approved for women, and 90% satisfaction rates are reported for women. So what about men? This is totally off-label for men. There are no studies about this in men, and this is a brand new device that really just came out this year, and it's been available for general use. So for women, it's very good, and for men, it's a mystery. But let's take a look at the machine. This is what the Emsella machine looks like with this high FEM technology. You sit down on this special chair. There's a magnet below you. There's a control tower next to you. The only contraindication is having a pacemaker because it might mess up the program on the pacemaker. And in women, the pelvic floor, which is sagging after they get treatment with the high-intensity focused electromagnetic waves, the pelvic floor becomes extremely strong and supports both the bladder neck and the sphincter muscle and leads to better control. It can also reduce urinary frequency and urgency. And the way this works is the electromagnetic waves cause contractions of those muscles that you try to contract during Kegel exercises about 1,000 times per second. And the feeling is described as intense, and some people think pleasurable. So a couple of anecdotal things from patients that I've had. The Emsella was great for me. I went from 8 pads daily to 1 light pad, which is mostly dry. It's a man who'd just been doing Kegel exercises for years. And another patient who thought the Emsella treatment was great and reduced the use of the bladder medication. His control returned, his leakage was gone. So it is something that's available. It's something that can be tried off-label. There's really no risk to the procedure at all. And it's not going to work for every single man, but it might be worth a try, certainly as an option to the other things that are out there, surgery or injection. So the next topic, as I was looking at the Arizona desert again, the saguaro cactus presents a very good metaphor for what men should feel like after their prostate cancer surgery. They should feel upright and tall and able to present themselves, without any trouble. But oftentimes, we don't feel this way. So when I talk to men about erectile dysfunction, I talk about the 5 things that I think are part of having a good erection. The 5 things are having intact nerves. Many times those are damaged during surgery or radiation. Testosterone has to be adequate. Blood flow has to be adequate. And a healthy response to the reservoir for the blood. And then the last thing is what goes on between your ears. A little bit of anatomy. The blood supply to the penis happens through 2 tiny arteries located deep in the pelvis, the internal pudendal arteries. And these supply the arteries to the erectile chambers, the cavernosal arteries. They supply the artery to the glans, penis, everything else. And then there's a whole network of veins that drain this blood out. And when an erection happens, first of all, there's a signal that goes from the brain down to the parasympathetic nerves. And these parasympathetic nerves stimulate the erectile chambers to relax. There's smooth muscle lining these erectile chambers. And as that smooth muscle relaxes, everything engorges. And that shuts off the outflow from the penis through this network of veins and keeps the erection rigid. If the chamber can't open up and can't accept blood, or if the blood flow into the chamber is inadequate, the erection won't happen. How do we improve these 2 problems? Well, down on a cellular level, you may be asking, what about Viagra, Levitra, all these PDE5 inhibitors? There's a magic thing called nitric oxide. It's released by the cavernosal nerves. It acts on an enzyme called guanylate cyclase, which transforms GTP to cyclic GMP. And that induces a decrease in calcium in the cell, which relaxes the smooth muscle cell. It's a very elegant mechanism to relax smooth muscle cells. And that's why those medications work, because as these smooth muscle cells relax, the chamber opens up, you're able to maintain a better erection. But what about when they don't work? what's happening and what's going on? Well, as we age, all of our tissues we know are becoming a little more inelastic, a little more calcified, a little less able to respond to the usual stimuli that you have. And can these tissues be improved or repaired? So the traditional therapy for erectile dysfunction, again, are the PDE5 inhibitors. Remember those drugs like Viagra and Cialis. An intracavernosal injection for the penis. You can inject yourself with a needle, or put a small suppository in the urethra, or use a vacuum erection device, or have surgery. But is there another option? So what about, instead of having to go and operate on somebody, if we could just make the tissues healthy again? What if we could fix the reservoir? What if we could fix the blood flow into the penis so that we were able to get a sizable erection? That's possible, and you can do it using platelet-rich plasma injection of the penis, low-intensity shockwave therapy for the penis, and also replacement of any low testosterone. So PRP is probably something that most people haven't heard about, but it's been in use for quite a while. PRP is platelet-rich plasma. It comes from our own bodies. When you cut yourself, you notice that first you get a bleeding wound, and then the tissue slowly begins to reattach itself. A scar forms, a scab is there, the scab falls off. The scar eventually fades away, and eventually you can't really even tell where you cut yourself. How does the body do that? It's amazing. It does it by releasing growth factors, which are contained in your blood, and those are contained in the platelets. So if you can separate out the platelets and use those in any body area that needs repair, it's going to be very, very helpful. So with PRP, people have used it for inducing hair growth, smoothing the face. They've injected it in every joint just about. Many sports injuries are treated that way. But it can also be used for erectile dysfunction. And the process is very simple. First, draw about 60 cc's of blood in a syringe and put it into a special machine called a thrombophoresis or a plasmapheresis machine. Ask the gentleman to apply some numbing cream to the penis, and then the PRP is injected into the penis in 5 different locations using a needle finer than a hair, very fine needle. And there's no downtime, there's really no risk, there's no complication, and the patient can resume all normal activities immediately, including sex. This is the thrombophoresis machine, and you can see the large syringe there on the right side, and then there's a smaller syringe next to that that actually collects the PRP, and that's what we use to inject. So what's the science behind this, or is there any science behind this? This is an article by Bano et al., 2016, from the Journal of Sexual Medicine. The PRP was applied to a group of men. They looked at their international erectile function scores before and after the PRP was injected, and it increased from 15.6 to 19.9. That's the average amongst the men. That's a huge increase. That's a 30+% increase in their erectile function on average. Wu, Xu, and Chang, in August of 2013, published an article in Journal of Tissue Engineering and Regenerative Medicine. They used PRP in a model in the rat where they induced cavernous nerve injuries. And they found that PRP repaired the cavernous nerves. And this was a follow-up to their article in Journal of Sexual Medicine from August of 2012, when they found the neuroprotective effect of PRP was created through increasing myelination of the nerves and also decreasing the expression of some bad factors, TGF-beta1, in the PRP group. So there is science behind this that's been looked at, actually why it should work. But you know, this is still a very, very new topic, and it's under investigation. Chalij, Grigorian, Epivanova, Karaznov wrote an article in Russian and found out that PRP was very effective in their Russian population, with and without PDE5 inhibitors. And then Kumar, CS, in the Journal of Sexual Medicine, November 2016, did a combined treatment of PRP and vacuum erection device for penile enlargement. This is a great study. He took 1,220 men who had a small penis for all sorts of different reasons and tried to see if there was an ability to make these penises larger. And what he found after a 6-month follow-up, he actually did 5 injections for these patients, 5 PRP injections. So with the first injection, the length gain was 7 millimeters and the girth gain was 5 millimeters. By the end of the 5th injection, the total length gain was an average of 35 millimeters. That's over 1.5 inches. And the gain in girth was over 30 millimeters. Those are impressive numbers. So in our patients, there's been definitely a spectrum. I would say 9 out of 10 men get a good benefit from their PRP injection, and maybe 1 out of 10 has little or no benefit from this. But the patients who are happy are super happy. This patient I had a PRP injection for the penis, and the results are fantastic. I'm happy, and my wife is happy too. But what happens when the PRP doesn't work? Is there any magic left in the wand? So we have to go and search that out. There was a treatment that grew out of the physical therapy world. It's called low-intensity shock waves. And it was used first for plantar fasciitis, used for sports injuries. It was used for cellulite treatment in the aesthetic world. It was used for all sorts of different therapies. And about 10 years ago, somebody wondered, could this be helpful for erectile dysfunction? And so the same exact device was used on the penis. And what was found out is that these small arteries and veins that have been clogged up and shrunken for years can be reinvigorated and made plump and open and release blood flow into the penis with shockwave therapy. So what is this shockwave therapy? The shockwave is 5,000 pulses delivered to the shaft and crura, which is the base of the penis, during a 20-minute session with a trained therapist. It's not unpleasant. No anesthesia is necessary. Some people find it pleasurable. 2 sessions per week for 3 weeks, no real risk of complications. And what are the results? What's the science behind it? It's a big article by Kalivianakis et al. In the Journal of Sexual Medicine in March last year, 2018. They used low-intensity shock waves for erectile dysfunction in a randomized controlled trial. They tried 6, 12, and 18 treatments, and they found that 12 treatments was quite sufficient. It was better than 6. The International Erectile Function scores all increased significantly after both 6 and 12 treatments. And very interesting was the mean peak systolic velocity, which is how fast the blood flows into and through the penis in the cavernosal arteries. That can actually be measured by an ultrasound machine. And this velocity increased from 29.6 to 35.4 centimeters per second. Again, that is a very significant increase in blood flow velocity, which can put you back, let's say, over the top. Another article by Liu et al. And Liu in the European Journal of Urology, February 2017. It was a review of low-intensity shockwave therapy in 14 articles. They just looked at what's the literature out there. Is this good science? Does it work? Is it a sham? There were 833 patients altogether, and they saw significant increases in all the International Erectile Function scores. Their conclusion was that, yes, this is a very promising therapy. And Srini et al. In the Canadian Journal of Urology looked at low-intensity shockwave therapy in an Indian population. They did a randomized controlled trial, a double-blind study. They had a sham arm where the people didn't know they weren't getting therapy. They did 12 sessions. They had follow-up at 1, 3, 6, 9, and 12 months. Before the therapy, nobody could achieve penetration. After the therapy, at 1 month, 78% could achieve penetration. At 12 months, 71% could still achieve penetration. So there are other articles up here. I'm just going to skip them for the moment because there is science behind this. There's been 10 years of papers and people looking at this. It works. And it's something that really should be offered to men as a therapy for helping their erectile dysfunction. One of my patients who had an open radical prostatectomy 10 years ago, and then 6 months after his PRP injection and his low-intensity shockwave therapy, said, I had a PRP injection followed by 6 treatments of shockwaves. I went from having only soft erections to having rock-hard erections. It's like the cancer never happened. I'm back to normal, and I couldn't be happier. And another patient, after PRP, I noticed more sensitivity, stronger erection, and an erection that lasts longer than I had previously experienced, all with no added medications. And Tim, after his low-intensity shockwave therapy, 2 months later, I had the shockwave therapy, and I woke up this morning with a serious erection. I would definitely recommend this procedure. And then Carrie B., 6 weeks after his PRP injection, said, my penis gets real hard. I'm 72 years old, and I'm tickled to death over it. I have much better sensation, and my penis erects real quick. He is a happy man. So when you're searching for rainbows, there might be a urologist's office at the end of your rainbow and a place where you can come seek some therapy. Additional topics for discussion in the future might be testosterone replacement in prostate cancer, the undeniable benefits of bioidentical hormone replacement therapy. That's sort of the third arm of treating the wellness of your erectile dysfunction. And then spinning the roulette wheel of active surveillance. These are for people who are watching their prostate cancer, how and why focal therapy can make you a winner. And then HIFU, high-intensity focused ultrasound treatment of prostate cancer, what your doctor didn't tell you about its incredible benefits. So Simone de Beauvoir said, change your life today, don't gamble on the future, act now without delay. And George Bernard Shaw said, progress is impossible without change. And those who cannot change their minds cannot change anything. So thank you very much, and I'll take any questions you have.
Yes, Doctor, very interesting. I think you got a lot of men's attention in here. I've read and studied on both of these subjects you talked about. The PRP, they call it a P-shot now. Okay, I've been reading up on these things, but there is a cost to it, and it's not really that expensive. I think at this point, what I've seen is no more than $1,800 to $2,000 to have it done.
It can be less than that, too.
Yes, it can be, but so this is what I've come across. So, but I just wanted to let you know that I've had did some study on that. I even had a conversation with one of my friends about it. So,
yes. Thanks. The P-shot is a proprietary name. It's just sort of an advertising thing that they use, but I prefer to just say what it is. It's a PRP shot. But P-shot sounds very compelling. But yes, sir.
Do most insurance companies cover these procedures?
Unfortunately, they do not cover these two procedures, the shockwave or the PRP injection, but or the Emsella. They don't cover any of those therapies. But we like to try to make them accessible. But there's some cost to it.
what's with seeing some of these advertisements, not for this but for other medications, and they would say if you don't have the resources for it, the company will pick up the charges. I forget which medication it is. They don't do this, right?
That would be great. I'd love to speak to these companies about doing some kind of clinical trials where men could enroll and actually get these therapies available for them. That isn't happening right now, but it's something that I think should happen.
Excuse me, over here.
Yes.
Are these therapies approved by the FDA, or are they need to be? And my second question is, we heard of all the good things. What are some of the unexpected things that happen?
Both great questions. Thank you. FDA approval is not needed for any drug or therapy. You can use therapies or drugs off-label. That's okay. The devices themselves are FDA approved, okay? But the use of the device is not an FDA approved use. So these are definitely being used off-label. The Emcella for women is FDA approved, but it's not approved for men, so that's an off-label use. Plasmapheresis, creating PRP it's an FDA approved machine, FDA approved device with all the parts that go into it. But the use of the PRP isn't necessarily FDA approved. And then you ask some of the bad things that can happen. With the shock waves, almost nothing. I mean, a risk might be a bruise on your penis. I've never seen it. Doesn't happen, as far as I can tell. With the injection, the PRP, same thing. A bruise could happen, but
A little swelling, they say, maybe.
a little bit of, yes, exactly.
No, I've been reading about it.
The educated guy. And then with the Emcella therapy, there's really, unless you have a pacemaker in place, that would be a contraindication, but there's no downside to it. You sit down fully clothed on this thing, just make sure you don't have your iPhone in your pocket or something like that, The magnet will kill it, but these are very, very safe therapies.
So, Doctor,
Yes.
I'm a little confused. In order to get the ball rolling, if I was interested in this therapy, I'd have to go to my primary care doctor or my urologist. I mean, is there open competition amongst you guys for different prices? And is this $1,800 to $2,000 bill, is that negotiable, or is that a one-shot deal? Do you only have to get this therapy once?
Those are all very good questions, so I'll take each question. So first of all, about competition, there are a lot of non-urologists who do some of these therapies. They may be an emergency room doctor who set up a clinic. They may be an esthetician, not even a doctor, other people. I thought it was important when I was looking at my practice and where I wanted to go to be able to help men to be well and not just help sick men in crisis. But, men who've been sick and in crisis need to get well after that, and this is part of that. So I thought it would be very interesting as a urologist to be able to offer these kinds of therapies. I try to make it, take everybody on an individual basis and try to make it as possible and affordable for them as I can. And it's certainly less than $2,000 or $1,800. Yeah, thank you. The other question, it is a one-shot deal. So you can do multiple shots. You can do more, and it might improve things even more along the way. But you can do one, and that can last for a long time because you're talking about regenerating normal, healthy tissues in an area. So if you have a shot, of PRP, your tissues are going to respond by healing themselves. It may take, a few weeks, a few months. Those tissues are going to keep improving. And then it matters about how fast your body ages before you might need another shot. Everybody, we're all snowflakes, we're all individuals. So everybody, is different. Sure.
What is the percentage rate of the people that come to your office to get this treatment, like from 1 to 10?
Larger and larger every day. So, it started out as a very small percentage, and now it's, around 20% of people coming in.
There's other effects. I do a little reading on this on and off, that diabetes can have quite an effect on erectile. Has that PIC can be affected with that type of?
It's very common to get small vessel disease with diabetes, and that's, again, something that's making the reservoir unhealthy. It's also making the blood flow into the penis unhealthy. And yes, that can respond to PRP quite well. So I've had many diabetic men who've had the PRP shot and done well with it.
Last question. Sure. Age. According to what that man testimony of 72 years old,
yes,
he was very happy about it. So is it, would you say the older you can look for a better outlook?
Like I said, we're all unique individuals. So I don't see age so much as I see a person who needs help. And it does matter sometimes if you're healthier or you're not quite as healthy. I do a lot of combination therapy. So one man may be great with just a PRP, and another man may require a little bit more intensive therapy. He may require testosterone, PRP, and shock waves, and some Viagra to get back in the swing of things, or something like that. So you can use multimodal therapy. But those are men who usually say, well, I tried the Viagra, it didn't work for me at all. And then we can get them back to the point where it will actually work for them.
Thank you.
You're welcome.
Over here.
Yes, sir. Lemmy.
Go first.
Okay. Hey, hi, Dr. Glick. I'm Lemmy.
Hi, Lemmy.
Okay. What I found out what worked for me was that I had my surgery in 2010. By 2014, I was having an erection. And what I found out what worked was that right after my surgery, when I was in the second month, I started with Cialis, and then I started with 100 milligram Viagra. And also, as far as me go, I used like visual stimuli to help as far as working on the mind part, as far as, like looking at sex tapes and stuff. I also found that, understanding of your partner. And like me now, I have no problem. I get hard, rock hard. But I think that's what helped in the intern, as far as the the therapy, the medication help with the, like you said, getting your blood flow going and everything like that. And like I say, me now, I'm like 6 years out. Especially when I got in my 4th year, I had no problem, and so on now. And it's building more and more, where I can think now like before, and I get an erection. I don't need, no other stimulant. I just started on the Viagra because I'm in a stressful situation. So just for a backup, I use it. But other than that, I don't need it. I'm 58 years old. I think that also has to play in it too, is your age, as you age. And also, what's your stress level that you're going through with the different guy, what your day is like or whatever. So that might be something to look into, as far as I just wish that I can get, like you said, you get loss of your inches. I wish we could do something about that. But as far, because me, I can have an orgasm and then rest for like 30 minutes, get it right back up, and just like that. Sometimes I can do it 3 times in a day.
You are
so-
exceptional. That's great. By
great.
any standards. That's
I'm grateful. I think the surgery had a lot to do with it too. Not too invasive on my nerves and everything. I think that has something to do with it. I don't mean to talk that way, but we all adults in here, and this is what a lot of guys I see in my group. I go to the Boston Medical Group, and I was just there last night. And that's what a lot of concern is with a lot of guys, is getting back to the normalcy of life,
Yes.
But that might be something to look into, is like start them on the pills right away.
We do that right after
Okay.
treatment, absolutely. And what you said, you're a great example of how somebody can start out with very good tissue, and by preserving the nerves and then doing the proper things postoperatively to preserve erectile function.
Yes,
very
yes,
good.
yes. That counts. Like as far as and the mental attitude. You got to think positive. That's what I tell a lot of guys in my group. You gotta be positive, and sometimes you gotta be patient. I'll stop right there.
No, thank you very much.
You're
Thank
welcome.
you. Yes, sir. Oh,
Excuse me, it's getting a little late. I think we're going to take one more question and perhaps a question from our live audience in other cities and other venues, just so we'll get some time to wrap up too. So, sir, you'll be the last one.
Fine, thanks very much. I wanted to address testosterone, because once you've had your prostate removed, a major source of testosterone is gone. And then if there's further treatment with hormones after that, testosterone added into that mix is actually going the wrong direction, I would think. So the question is, how does testosterone fit into the treatments that you're talking about, and is it essential, or can you get by with very little testosterone, so especially in people that are going through hormone treatments after their prostatectomy?
right. For men who need androgen deprivation, they can't have testosterone, but they can have estradiol, which is something all men have. Women have it too until the point of menopause, when nature takes away all their hormones. So men can be treated hormonally even if they have to have androgen ablation, because estradiol is important in preserving muscle health, energy, vigor, bone health, and brain health. As far as testosterone and prostate cancer survivors who've already been treated, in my practice, am able to safely monitor people who have prostate cancer or who've been treated for prostate cancer who have low testosterone, because low testosterone puts you at a higher risk for prostate cancer. And high testosterone doesn't put you at a higher risk for prostate cancer, quite the opposite. It makes you healthier. So testosterone is one of our own bioidentical hormones. It's in our bodies. We make it. It's important to have enough testosterone, both to have enough energy, libido, well-being, mental clarity, and also strong bones and strong brain. Okay. The generally accepted value is if below 300, it's not enough.
And that's through a blood test?
Yes, sir.
I just wanted to check to make sure that is there anybody online that has any questions from other cities, other meetings, by any chance? Okay, great. Well, this has been a very exciting meeting, really. We got started a little late, so we've gone over a little bit, and I hope you guys don't mind very much. I just wanted to tell one personal story. I did have the Emsella treatment for my urinary incontinence, and I wanted to sort of share how I came about making that decision. I tried every single medicine and every single combination I knew of to stop peeing on myself, and I couldn't do it. So I was at the point where I was ready to consider surgery, and I went to see Dr. Gluck, and he told me about this Emsella stuff, and I did my homework, and it is FDA approved for women. Although I'm not a woman last time I looked, I thought it was worth a shot, especially when considering surgery, because I certainly did not want surgery. So I went on and got the Emsella treatment. And what he didn't say is it takes about 3 weeks. You go twice a week for, I think, 3 weeks. And I felt an effect right away. Now, it's not 100%. You know, I still go running every day, and I still leak on myself when I pick up things that are heavy. But it is much better than what it was before. I'm no longer considering surgery. Best $1,800 I could have used. So I'm not giving you an endorsement, but I'm just telling you how I came about it. And if it worked for me, then I'm sure it can work for some people here. Well, that's about it. Thank you all very much for coming, and your questions were absolutely exciting. Thank you. And I also want to thank our guest speaker, Dr. Clifford Gluck. Thanks.